So listen, everybody, welcome. I'm Tina Saryeddine. I'm the Executive Director of the Canadian Association of Fire Chiefs. I am the moderator for today's session. I don't usually do these things, but I have imposed over and over and over again on our board members and our membership who have spent incredible amount of time in Ottawa advocating for the fire sector and their needs through Government Relations Week earlier this week. Our president and board members who have been in the media nonstop, as well as meeting with senior officials, and so many members who were here in Ottawa and now today in the audience. I just want to say thank you to everybody. CFC asks a lot of favors from a lot of people, and it's a team sport and everybody joins in. And I just want to say how grateful I am to all of you for being here, both of our speakers and our audience members. So for the audience members, our wonderful Director of Operations, Ms. Annabelle Thérien, has created an invitation for you to join what we know as Worldly. And if your preferred, you can choose your preferred language and you will have captions of this discussion in your preferred language. And I think, Annabelle, is that live or is it just me that's seeing it?
No, it's live for anyone. And one note I will make is you can resize your window if it covers any of the panelists.
Thank you so much, Annabelle. Thank you for discovering this technology and bringing it to us so that people can follow along in the language of their choice. There's also a second piece of technology. And while our experts are here on the screen as physicians and researchers, I know that there are also experts in this topic in the audience. So this conversation is called How to Talk to the Doc. And if you know me, you know that I like alliteration and things that rhyme, and I thought it was cute, but I also thought it's a good title for this topic, because that's exactly what we're going to talk about. Now, it occurred to me as we were listening to the first four, this is the fifth workshop, that there are a lot of people who also know how to talk to the doc, and that is because they've had experiences that are up close and personal. And I know many of them are in the audience, and some of them who have had conversations on this very topic, maybe didn't know the answer to the question when they started out, when they needed to know, but have some real good insights now. And so I'd like to invite everybody in the audience to follow along on Menti. Menti will allow you to put your own perspectives in as you listen to the panel discussion. So Annabelle has put in a code. You're going to need your smart device for that. And it's the same as we've been doing for the other sessions if you've been here previously. So with that, I have the tremendous honor of welcoming our speakers. And I'm going to ask you speakers to please introduce yourselves. And I would like you to not be too modest and explain the different hats that you wear that can be very useful to this conversation. If I do it for you, but I don't want to miss anything. So I'm going to start with, and I'll give a hint to Fire Chief Dr. Petrak. So you can tell us a little bit about yourself and the hats that you wear that can be relevant to this conversation. And then I'm going to go to you, Dr. Liu, and then to you, Dr. Kunz.
Okay. Yeah, thanks so much, Tina. And first off, I'd just like to thank CFC and Health Canada for putting on this workshop. I've attended all the sessions and it's been fantastically informative. I think it's such a timely opportunity to bring this really important issue forward, and we've had amazing discussions. So thanks very much for that. So my name is Jim Petrak. I have a couple different roles. One is I'm a translational cancer researcher at the University of Guelph, lead a cancer research program focusing predominantly on ovarian and pancreatic cancers. And then we're also moving into some brain cancers as well. We're looking at the development of novel therapeutics for treatment of advanced stage disease. The unfortunate reality is that some of these cancers are really challenging to diagnose in the early stage. And we understand that the current clinical picture is that most people are diagnosed at advanced stage, and we're looking at novel therapeutics in that situation. And we have we're going to clinical trial in advanced stage ovarian cancer hopefully next year, and then we're anticipating pancreatic cancer the year following. So we're really excited about some of the work that we're doing. I'm cross appointed in experimental oncology at Western, and I teach at the med school at Mac. So I have some opportunities in some of the healthcare fields with some of the translational cancer research. And then the other role that I have, as you can see with what I'm wearing today, is been in the volunteer fire service for 26 years. I've been the fire chief in Guelph Mouse Fire Department in Rockwood for the past 7 years, and been a member of the CIHR Cancer Committee for the past couple of years. So really excited and honored to be here, and looking forward to our discussion. So thanks so much.
Thank you so much, Chief, and thank you for participating on the Cancer Committee and coming here again today to be with us. So much appreciated. Dr. Liu, welcome. We're honored to have you. Please introduce yourself.
Yes, so thank you so much, Tina, and thank you as well to the CAFC and the Health Canada for organizing this conference. I am definitely not an expert in this panel. I am a card-carrying radiation oncologist at the Princess Margaret in Toronto, so I do treat cancer patients at the front line. My expertise is breast cancer, but and in addition to being a translational cancer researcher for the last 30 plus years, where we try to discover novel biomarkers for cancers, such as in breast cancer, head and neck cancer, etc. I am, for the last 10 years, I had been the head of the Department of Radiation Oncology at the Princess Margaret, and as well as the chair of the University of Toronto Department of Radiation Oncology. So I also have firsthand experience on managing a very large program, both academically in the world of primary cancer care delivery, as well as training the next generation of radiation medicine professionals. So I do have a lot of the administrative experience. And then just starting September of last year, I acquired this new role as a scientific director of the Institute of Cancer Research at the Canadian Institute of Health Research, CIHR, which is Canada's largest funding agency for all aspects of health research, from cardiovascular, aging to cancer, and we have, of course, also funded Dr. Petrick, and so I am new to this role here, and I am here really to learn as much as I can, and I do confess that until I played this role, I was unaware of cancer and firefighters. And so since then, I've done a lot of reading and have been really quite astounded by what I have learned. And so I'm delighted to be able to participate, to advocate, and to be able to learn about the underlying causes of this relationship and what we could do to try to understand it, as well as to try to prevent it. And so I'm really here more as a learner, and I'm really delighted to be amongst this panel of learned people. Thank you.
Thank you, Dr. Liu, and I'm sure you're far too humble and far too modest. Let us learn a little bit from you in terms of, can you say a little bit more what a translational researcher, translational scientist is?
So I guess in terms of cancer research, there's a whole range between the fundamental cancer biologists like Dr. Petrick, and then all the way to clinical trials, to population health, etc. So the translational is where we evaluate, for example, patients' tumors, and then trying to understand what might be the biomarkers for to be able to help in terms of patient management. So as an example, one of the contributions that we had made in the world of breast cancer was that we were amongst the earlier identifiers that there is a group of very, very low risk breast cancer, such that these patients may not actually require local breast radiation therapy. And so we had made that one of the earlier reports about 14, 15 years ago, and now that is becoming actually standard of care, that this group of what's called luminal A breast cancer patients might not require breast radiotherapy. So that was done through the analysis of women who had participated in clinical trials, in studying their tumors, and then understanding some of the basic biology, then to translate that, if you will, merging the information from the fundamental lab to the clinical application.
Thanks very much, Dr. Liu.
Thank you.
And Dr. Kunz.
Yes, my name is Kenneth Kunz. I'm formerly trained as a medical oncologist and molecular pharmacologist. I saw my first firefighter in the emergency room in 1984, and I've been providing medical services to firefighters ever since then.
That's nicely said. And I also happen to know, Dr. Kunz, that you have been doing an awful lot of writing about firefighter cancer, and that you have several publications, and that you've compared all of the provincial legislations. Is that correct?
Yes, I like to write about firefighters because I believe that they're desperately underserved. You know, they lay their lives down for the public. And I don't think the public has done a very good job of looking after and protecting firefighters. And somebody's got to do something. There's a lot of really good people that I've worked with over the years. But the rubber has got to hit the road. As I mentioned in the last conference, you know, recently the International Association for Research on Cancer recognized, they confessed, they admitted that cancer, that firefighting was carcinogenic, but nothing's been done. It's like discovering a new drug and not using it. We need to draft cancer legislation guidelines, you know, with the Canadian Preventative Services Task Force and the United States Task Force on Preventative Healthcare, and we have to draft guidelines. Oh, darn, there's the phone. Yeah. So yes, we've got to do something, and the time is now. So I congratulate you, like all the other panelists, for conducting this conference.
Thank you, Dr. Kunz, and thank you all for introducing yourselves. And sorry, I pushed you to say a whole lot of things there. And I echo your thanks to the fire chiefs, the audience, Health Canada, for allowing us to do this and for all doing it together. Appreciated. So let's get the rubber on the road. Here's the question. How do we influence physician awareness of firefighter cancer? And I'm going to start with our two physicians, and then I'm going to go to our fire chief and researcher. And yeah, let's start the conversation with a broad question, and then there might be some sub questions under that. So who would like to go first? Not all.
I can unabashedly start off, because
Okay.
I find this to be a very intriguing question. You know, the question is, how do we influence physician awareness? Okay, so let's consider a similar question, like we'll do a thought experiment. Let's say we wanted to influence the behavior of a Tasmanian devil or a mongoose, something like that. We would have to learn about this animal. We have to learn about its habits. Where does it live? What does it eat? What are its characteristics? And if you want to influence the behavior of a physician, you have to understand about physicians. Let me tell you about my own personal experience. This may not be Dr. Liu's experience or any of these other physicians that I work with, but let me tell you about my experience as a doctor if you want to influence my behavior. I went to medical school with no money. I had to apply for student loans. I went to an undergraduate program that required 4 years of pre-medical studies, which was brutal. I was competing against thousands of other students. I had to get straight A's, which meant often staying up all night studying, you know, because you're carrying a very heavy course load and you need a 4.0 grade average, and you need a very high mark on the MCAT, which is a screening exam. And after 4 years, during which time I was able to capture the gold medal in chemistry and publish some papers, I was accepted into medical school out of about 2,000 other potential applicants. So you have to be obsessive compulsive, a grade A personality type to even get in the door. Like, you almost have to be a tragic self-sacrificing martyr to get into medicine. I don't know what everybody else's experience has been, but I had a devil of a time. And then surviving medical school, like, you don't have any money. How do you pay for your tuition and books? I was living off of mashed turnips and Kraft dinner. I survived a 4-year program, then got into a rotating internship where I was paid a minimum wage. You work 36-hour shifts. The longest shift I worked was 52 hours at St. Boniface Hospital in Winnipeg. If you survive this, and some don't, you can get accepted into a specialty program. I chose internal medicine. It was 3 years at a military hospital in the States. And you're subjected to all forms of deprivation and abuse. You know, you're on call every 3 days. When you're on call, you admit 20 or 25 patients from the emergency room, and then you're responsible for their care until discharge. You're not making much money. You have no outside life. I remember when the space shuttle crashed, somebody said, "Hey, did you hear that the space shuttle blew up?" And I was like, "What's the space shuttle?" Because the outside world doesn't exist. That's why you're called a resident. You live in the hospital. That's all you see and do. And then if you survive an internal medicine residency, then you can get into a subspecialty program like medical oncology. So by the time that you get out into the street, you're almost exhausted and burnt out. I'm not talking for all doctors, but this is my experience. So I remember being released out into the daylight on a day in July in Tucson, Arizona. And I was thinking to myself, what do I do now? I mean, I was pale, pasty, exhausted, and then I had to start, find a job and start my career. Any doctor, and we're talking about, if we want to talk about family practice doctors, has between 1,000 and 2,500 patients that they're responsible for. So as a medical doctor, I was recently asked to give a talk at the Kelowna Cancer Center. And I gave a talk on kindness and resilience among physicians. And I said, why do you want me to come and talk about, mental health and addictions in doctors? And the cancer director said, because all of my oncologists are depressed and suffer from anxiety. So now you're a doctor, let's say you're a family practice doctor, and you've been through all of this. Also, doctors are subjected to a lot of abuse. Like during my training, you're abused by attending doctors. Nurses take advantage of you, when you're a junior doctor. I mean, it's a tough life, and so that's the telephone. See what I mean? Like you're a doctor, the telephone rings every 2 or 3 minutes, okay? So you've got 2,000 patients. You have machinists, bus drivers, police women, bricklayers, tool and die workers, people who work in the chemical industry. You have thousands of patients. Then one day a firefighter comes into your office and says, "I'm a firefighter, I want special treatment." And you're like, what are you talking about? Like most doctors, I trained as a medical oncologist, and Dr. Liu will back this up. Most doctors do not know that firefighters are subjected to higher incidence of cancer, or they die more frequently of cancer. I was a medical oncologist. I treated firefighters in my clinic. They were on my bone marrow transplant ward for leukemia. And there were so many patients, and they were so sick, and the diseases were so severe, and the turnover was so rapid. And then also at the same time, I have a private life where I'm married and I have children and bills to pay and insurance, and there's lawsuits, and it's an absolute melee. This is my experience, that maybe not Dr. Liu's or other doctors, but a doctor is exhausted and burned out. Then a firefighter comes into the office and says, "I want special treatment," and you're like, who are you? You know what I mean? So the problem is, in order to understand why doctors don't know or are unaware or are reluctant to help, is because they're human beings who are largely overworked. They have information overload. They have thousands of patients, and they simply do not know or are too tired to care. And I'm not going to say anymore. I realized that was full of passion and fervor, but this has been my experience as a cancer doctor. I simply didn't know that firefighters got cancer, and many times I was too tired to care.
Thank you for the candor, Dr. Kunz, and understanding some of the factors is how we can get behind some of the possible solutions. So thank you for that. Dr. Liu, your take.
Yes, so it sounded very traumatic, Dr. Kunz, your story. But I do completely agree that the physicians, in particular the primary care physicians, we do know that they're disappearing in droves, and 15% of Canadians do not have access to primary care physicians, and they would be the first point of contact with our firefighters. And and as I mentioned at the very beginning, I, even as a cancer physician, was not aware of the association between cancer and firefighters. So I think that we do have an awareness issue here. And I think that therefore, and what Dr. Kunz had mentioned in terms of the Canadian Preventive Task Force on healthcare, they're the body at the federal level which defines a screening program. So for example, breast cancer screening, that's undergoing a little bit of controversy, but the guidelines in terms of screening for women over the age of 50 every 2 years, that is a national guideline that's developed by this preventative task force. And so I do agree that one of our first point of contact perhaps would be with this national body, and to kind of say, here's the evidence of the relationship, strong relationship between cancer and firefighters. Can you please evaluate the evidence? Because it is usually comprised of a group of primary care physicians, as well as PhD scientists in epidemiology. So their role is to gather all the evidence, look at all the literature, and then develop guidelines to really help the primary care physicians understand about how to help firefighters. And so I think that would definitely be one first point in terms of the providing the aid, if you will, for primary care physicians in terms of the appropriate screening. So the screening for mammograms, I think that, for example, is pretty straightforward. I mean, everybody does that, right? So that's the kind of level of awareness, but it has to start at that federal level. I think the other things, like, I don't even know if in medical school they're teaching these types of no. Okay, the answer is no. Okay, well that's another. I think it's a multi-pronged strategy that we have to undertake in terms of awareness. And so, what would be the most appropriate strategy to have this introduced into the medical school curriculum, so that the medical students, as they're going through their training, that they become aware of this entity, and so therefore that raises their level of knowledge. And I think that these types of fora where we're meeting amongst ourselves, I'm sure that there also needs to be a communication strategy more broadly, through publication, scientific. I mean, physicians, when they do have the time, do read scientific articles. And so in terms of, changing the practice, there are sort of conventional strategies and platforms of communication of scientific knowledge, such as presentations at conferences and publication in peer-reviewed journals, et cetera. And of course, there are also other, mainstream media, social media, et cetera, in terms of getting this message out there. So those are some of the things that I would recommend that we think about which I'm sure you have thought of as a community. But I think a lot of it has to do, in addition, I'm sure this will be one of the things that we would also be talking about, is increasing that capacity. And that's where our role at CIHR, because part of our responsibility is also the training and building that community of researchers in this very area, which I don't think is huge right now. And I'm sure that Dr. Petrick knows more about that community than I do, but I think that we have to also build that community so that there are more people who are able to also speak to this with expertise and data. Thank you.
Thank you, Dr. Liu. So with those recommendations, do you know some people who might be able to help us with that in terms of reaching out to those that create the national guidelines for screening? Yeah.
Yes, I do. I mean, I don't know them personally, but we had just been on a call or a virtual meeting related to breast cancer. So I know who those two co-chairs are, but I don't know the structure well enough to know whether, I imagine there's probably a different group of people, but I'm sure that there is we know that there's an organization, and then therefore, yes, I would be happy to reach out to those people and to kind of say, have I just signed up for a job or something, Tina?
That's what the fire service is all about. Welcome.
Yeah, right.
Okay.
Yeah, be happy to connect with the
Thank you.
people who are in charge of this type of structure, and to kind of say, well, what's the process, for us to introduce this as a topic for you to examine and evaluate, right? So I think
Thank you,
there's
Dr.
presumably, I'm sure there's a process for this. Thank you.
So much appreciated. We're very honored to meet you. Thank you. Dr. Patrick, Chief Patrick, do you have anything to add on
Well,
this?
the one thing, and Dr. Liu mentioned it, and I think we really need to get into the medical schools. I think the grassroots approach to it always seems to be the most impactful way to enhance awareness and enthusiasm. And I think if the the CFC Cancer Committee was able to get some messaging, or patient partners are such an increasingly important part of translational medicine. If we were able to get in and talk to the medical students, and if they were made aware that firefighters that are serving their community very selflessly in many ways are being challenged almost universally by this such heinous incidents of cancers, I think they'd be really motivated, and I think that would resonate with them. And as they build their medical careers, I think that having that upfront awareness would be such a valuable investment in terms of increasing their awareness and their desire to really meaningfully connect with the firefighting community in a preventative and a therapeutic way. So I appreciate you bringing that up, Dr. Lee. I think that could be such a big payoff in the end. It's not immediate, obviously. It's an investment in time, but I think it would be really important.
This is great. Thank you, Dr. Patrick. Thank you all for the answer to that question. So you've talked a little bit at the system level about how we create sort of the infrastructure that helps physicians system-wide to recognize firefighter cancers. What if we flip this on its head and said, for those individuals who might have concerns that they might have something that looks suspicious. Some of our panelists yesterday talked about knowing their bodies, knowing something's not quite right. Maybe the literature doesn't say that, but I don't feel like myself. Do you have recommendations for those individuals when they talk to their family docs or their oncologists or whoever they're going to be speaking to? And I know somebody said it's not just the physicians, it's the entire medical system. Do you have recommendations for how they talk to the doc, just as some of those system initiatives are getting started? And I'll go to Dr. Kunz first.
Well, any patient is their best healthcare advocate, and that goes double for firefighters. Firefighters know that they get cancer more frequently and succumb to cancer more often than the general public. So basically, society has to recognize that if we hire a firefighter, there's a high likelihood that they'll acquire cancer and die of it. So we have to be prepared when we hire a firefighter to protect us, that we look after them and their families when they get cancer and they die of cancer. So that's the first thing. We have to recognize that firefighters get cancer and they die of it. Furthermore, every firefighter should have a primary care physician who believes the scientific evidence that firefighters get cancer more frequently, and firefighters should begin cancer screening and surveillance 10 years sooner than the general public. And, my experience as a specialist in medical oncology is that the therapeutic alliance, which is the relationship between the patient and their doctor, is a primary factor that will confer a survival advantage on that patient. So if every firefighter had a family practice doctor who saw them once a year, and the doctor sat down, looked at the firefighter in his eyes and said, "How have you been doing? Have you noticed anything new?" That right there will save hundreds of thousands of lives. That simple question right there. How are you doing? Have you noticed anything? Any changes in your health? So I forget exactly, what the question was, but, we have to recognize that firefighters get cancer and they have to be provided with services, which include primary health care. and all the rest of it, you know, coming down the line.
You,
So
you
that
did answer the question, even though you didn't remember it. It was about how individuals can approach their physician. Do you have anything to add to that, Dr. Luke?
Yeah, no, I completely agree with what Dr. Kunz had just said, right? So it's absolutely, yeah, I mean, but circling back to Dr. Kunz's earlier comments about the burnout of primary care physicians, right? It is, I mean, under ideal circumstances, there's a very good, what we call therapeutic relationship, a relationship between a patient and his or her family physician is ideal. And if that relationship has been built up, particularly, you know, over years, and it's very productive, that would be, and what Dr. Kunz had outlined about sitting down and saying, you know, once a year, how are you doing? Are there any issues that you're concerned about? I completely agree. That would be the ideal circumstance. But I'm a breast cancer doctor, and I have my patients who come to talk to me, not about breast cancer anymore, but about, you know, like renewing their sleeping pills and having, you know, discomfort that has nothing to do with their breast cancer, which really is an illustration, I think, of the stresses in our primary care system. And then patients, you know, and as we said, 15% of our Canadians do not have access to primary care. And so that becomes a bit of a challenge. But I think the overall advice that Dr. Kunz had provided, and that is that having that, you know, healthy conversation with your primary care provider would be the best way to kind of say, you know, I've got this cough that I haven't had for you know, I've never had a cough like this, and it's been there, and, you know, and I'm coughing up blood every now and then, or, you know, what do you think? I'm a bit worried. What do you think? Right. And then, you know, with family physicians, should they therefore be undergoing those other additional tests that would be necessary to work through that particular symptom and or sign.
Thanks very much, Dr. Luke. Dr. Patrick, as both a fire chief and a volunteer firefighter and a researcher, what's your take on this topic?
Yeah, I think I have spoken, as you know, we have a CIHR grant looking at firefighter behaviors around this issue. We're also writing a grant application to CIHR and Cancer Research Study about the physicians' awareness and perceived competencies around dealing with this group of individuals, because I've talked to a number of family physicians, and as you mentioned, Dr. Liu, there's a real pervasive lack of awareness that this is a special group that comes with special needs and has different incidents of many different cancers. So I think enhancing the awareness globally. So I know the question was, how does a person go talk to the doctor? But I think we're in a difficult position, because if the physicians don't have full awareness of the problem, I think that's one of the first steps is trying to get a universal understanding in physicians, but more importantly is giving the physicians the tools. And I've seen in the chat, there's been a number of comments that, hey, I've gone to my doctor, but they don't have the opportunity to provide these special tests because they don't fit in. Like, it's not like a familial, like in ovarian cancer, if you have these specific genetic mutations, well, now you're in a different group that opens up opportunities for imaging and diagnostic tests, et cetera. What we need to do, and Kenneth and I have talked a bit about this, is connecting with the group that allows those opportunities to identify firefighting as a specifically hazardous occupation that will then provide the physicians with the opportunities that, yeah, you've been a firefighter for 15 years, you have some symptoms, we can now provide these tests that I otherwise couldn't have. And I think that's the most critical need right now, is providing awareness, but also providing the legislation that will provide the doctors the opportunity. But from the firefighters' perspective, as we mentioned, I think there's a tremendous amount of awareness that needs to be done on the firefighter side in terms of general cancer awareness. What are the signs and symptoms of cancers? Because I know before we started bringing this forward in my fire department, for example, there wasn't a significant increase in the awareness of the firefighters of cancers, even though they're significantly more likely to develop them. It's a group that we have to target with awareness programs in terms of what are the signs and symptoms of some of the cancers that we're seeing in firefighters, so that they're aware, they're educated, and they can self-monitor. As Dr. Kunz said, you're your own best diagnostician, but you need to have the information. You need to know what are some of the potential signs and symptoms. So I think we need to increase the education and awareness of our firefighters of some of the early signs of some of these diseases, so they can then go from an educated perspective to their doctors, and really, increase the awareness of all members of the team, the patient, the physician, and researchers in a lot of cases as well. So there's a lot of work to do, and a lot of it is awareness and education in my mind right now.
Thanks very much, Jim. Well spoken. And I like how you identified both opportunities at the system level, which won't happen immediately, as well as at the firefighter level, but also recognizing that the firefighter can't change the system on his or her own. And we have a comment, what if you don't even have a family doctor? So all of those elements will go into our reports. If we're not answering directly, please know we're seeing them, and these are points that we want to integrate. I kind of know the answer to this because it came up in the previous panel, but for the sake of our conversation, making sure that we're documenting these wonderful opportunities, are there some tools that have already been developed that would be very helpful to firefighters and physicians alike that could help to further the conversation faster? And I'm going to start with you, Dr. Kunz.
Tools.
Yeah.
The question is about tools, like what
Yes.
tools are available to facilitate discussion with physicians regarding firefighters and their cancer. There are very few tools. The tools are scarce because, as I said in the last panel, firefighters have been dying of cancer for thousands of years, we know. But the recent phenomenon of cancer in firefighters is something that has just been recognized last year by the World Health Organization. The World Health Organization reluctantly admitted that firefighters die of cancer. So now we need to put tools into place. What kind of tools do we need to put into place? You know what we need? We have to go to the Canadian Task Force on Preventative Healthcare Services. And we need to say, just like women who have an ovarian cancer gene, or somebody who has a P53 tumor suppressor gene, firefighters are at high risk, as if they have a familial cancer syndrome. And we need a special category for screening firefighters, so that when a firefighter goes into his primary care doctor's office, if there are there any primary care doctors left? I know that 70% of the population of Victoria, where I live, do not have family practice doctors because they're burnt out, retired, or they're not trained. But if a firefighter is lucky enough to have a primary care provider, that firefighter could go to their doctor and say, I'm a firefighter, and the doctor will look down the list and say, oh yes, you're a firefighter? There's a special category for that. We can order, you're 40 years old, we can get a low dose CT scan of the lungs. We can do prostate cancer screening because adenocarcinoma of the prostate is a problem in young firefighters. We can screen for gynecologic malignancies, with the PAP test and, do a skin survey. So we need to give doctors the tools that they need that will allow them or even encourage them to legitimately screen firefighters at an earlier age. And this won't happen until we do it. That's the next thing that has to happen. Medical doctors, physicians, and scientists have to write a paper and publish it in a journal like JAMA, the Journal of the American Medical Association, or the Journal of the Canadian Medical Association, and say, look, colleagues, we now recognize that firefighters are dying of cancer, so we need a special category for firefighters. Then we have to lobby these, like the United States Preventative Services Task Force, and get this category added, and then we can screen away and watch the mortality rates fall in firefighters. That's my comment on that topic.
Thanks, Dr. Kunz. And are you willing to help with that?
I'm working on it as we speak.
I thought our audience might like to know that. Thank you. Dr. Liu, what do you think?
Oh, I completely agree with what Dr. Kunz has said. I think the other thing that is interesting, you mentioned the U.S. Preventative Task Force, right? And so I think working with both organizations and lobby both organizations to, I mean, they don't work together, the Canadian and the Americans, but they do definitely influence each other. So for example, when the US Preventative Task Force recently lowered the age for mammogram screening, that definitely catalyzed the Canadian group to also advance their evaluation of the data as well. So
That's why I want to go after America first, because, you know, when America approves a new drug for cancer, it's not approved in Canada. The Americans approve it first. The Canadians watch and wait, you know, because we're socialist, they're capitalist. We watch and wait what happens. Then 2 years later, if there's good results, we approve that drug. Sometimes that works to our benefit as Canadians. For example, when the Americans legitimized and promoted thalidomide as being a phenomenal anti-nausea agent in pregnancy, Canada waited for a couple of years. And so we didn't have the catastrophe, the disastrous catastrophe of thalidomide on the scale that the Americans did. So, you know, being more conservative Canadians watch and wait. But my primary target, if I was like a cruise missile, would be to go after the United States Preventative Services Task Force. And I've been talking with Rebecca Kaltman at the Fairfax Cancer Center in Virginia about getting an initiative going after them and just saying, look, we need to add firefighters as a special category. And then Canada will follow suit on its own after that.
Great. You work on the Americans, I'll work on the Canadians. We have a plan.
Deal. Thank you. In our last panel, one of the physicians who was there, who's also a senior official, said, the science hasn't always kept pace with reality. We have the science, but it hasn't always helped us. Dr. Patrick, do you have any comments on that statement?
That's kind of a tough statement, but you know, I think what I got out of that was that there's a disconnect between the research and then the timeliness of application of the research and that translation to clinical application. And I'm a translational scientist. We're taking things to clinical trial. I'm unfortunately fully aware of the amount of time it takes to institute that. All I can say is, we continue to look for funding mechanisms for this, and CIHR has been a fantastic partner for this type of translational health research. I think the research funding to conduct these basic scientific programs that then translate to clinical outcome is really critical. One of the things that I very strongly promoted in my research program is a full translational spectrum in a research program. So I'm a basic scientist, but on my team I have clinician scientists, I have clinicians that run clinical trials. Very importantly, I have patient partners that are part of our team. I can't overemphasize the importance of bringing patient partners. And for the group that's here today, firefighters that have been or are cancer patients, there's a world of opportunities to have impact in research programs and clinical management. I give lots of talks at survivor groups, pancreatic ovarian cancer survivor groups, and they're very motivated groups that sit on grant panels. They're part of large research teams, and the input from patients can really help direct and accelerate research. And I very strongly encourage anyone that is part of an organization or can become part of an organization that has connections to researchers, clinicians, et cetera, that can have significant impact. So the science is being worked on. I can tell you, we're working on it as hard as we can. These are really big, difficult problems. Translating them to clinical application, I think that's an opportunity where we can accelerate that in some cases, and the patients themselves can be part of that process. And I so value the input that I've had from patient partners in my research program, and I strongly recommend people that to get involved if they can.
Thanks, Dr. Petrick. The research process is known to take a long time. So I think CIHR says it takes about 17 years for research to get into practice. Can any of you talk a little bit about why it takes so long? And is there a different way of using researchers to help expedite care for firefighters that are facing very scary situations now?
So maybe I can jump in. So, so one of the things that that Drs. Petrick, Kunz, and I discussed just before this panel started was about engaging the CAMPATH cohort. So CAMPATH is Canadians' cohort for tomorrow's health, and it has been in existence since 2008, so for about 15 years. And it's Canada's largest, with 330,000 adults who have participated in, in completing questionnaires. It has demographic data, it has socioeconomic data, lifestyle data, medical history, family history, the entire spectrum. And they also have biosamples that have been collected over a period of time. And it covers coast to coast, from BC to Atlantic provinces, with the prairies, Ontario, Quebec, et cetera. And within that 330,000, my understanding is that there are 600 individuals or participants who have self-identified as being firefighters. And so I think that that's a huge opportunity that we're encouraging to utilize the CAMPATH infrastructure. We're able to recruit individuals and to develop a subgroup specifically for firefighters, because it's through that mechanism where we follow individuals over a period of time, over, this so far it's been about 15 years, but ideally for a whole generation, at least for about 30 to 35 years. And then you study who are the individuals who are going to develop cancer. And then you look at what has their sort of exposure been in contrast to other individuals, like other firefighters, who have not developed cancer. So what is that complex interaction? As Dr. Petrick has already, the issue is complicated, right? In terms of the interaction between the host genome, what I'm born with, and then and how has my host genome interacted and been affected and influenced or not influenced by what I have been exposed to, right? And so that is a strategy by which I think we can garner the most important information, the most important insights for us to then subsequently figure out how to prevent them in the first place, right? And so I had reached out to our American colleagues already. So there were these two scientists who are co-leading a FEMA-funded longitudinal cohort specifically on cancer and firefighters. And they have about 10,000 firefighters in the US. And these two individuals, Drs. Jeff Burgess and Judy Garber, are just absolutely fantastic. And Dr. Kunz actually knows Dr. Burgess. And so as one example of the rapid translation of the information, so everybody, I think, in this room know about PFAS having just been escalated to a proven carcinogen. And so what these investigators have already done is had measured, I think it was urinary PFAS levels amongst new recruits in LA. And so in the LA, the way that, I don't know how things are done in here in Canada, but the recruits were trained, and the training took place in wherever the training took place, in the fire hall in LA. And they had a large cohort. They were divided into two groups, group one and group two, and the group two followed the group one immediately. So what did this group find? The scientists have found that when they measured the urinary PFAS levels, it was hugely elevated in the second cohort. And the reason I gather is that they were, practicing how to put out fires with the fire retardants, and it had PFAS in it. And then not surprised, and so therefore they didn't clear the environment. And then this poor second group of cohorts of recruits were therefore exposed to this, environmental exposure. And so, needless to say, LA has completely changed the way that they train their recruits. And so that's almost like an immediate application of information that's measured in a scientific environment, and then immediately then applied and obviously benefiting the new recruits. So to me, that's a rapid translation, and things that we have to do also here in Canada. So I don't know if any Canadian firefighters are trained that way, but we should stop that.
Thanks, Dr. Liu. Dr. Patrick, were you trying to get in on that one?
I'm just aggressively agreeing with Dr. Liu. Yeah, there are some examples like that, very tangible, rapidly translatable, kind of procedural things that have really evolved as we understand some of the chemistry of some of the compounds that we're working with. The biology of the cancers is things that take historically a little bit longer to wrap our heads around, but we're definitely working on it for sure.
Okay, so we're coming towards the end of the times, but this is a tough question, and then they're going to get easier. So in our last panel, one of the panelists said, with all due respect, we have had paper after paper after paper, and we're still asking people which fire they went to when they're trying to get access to care. Dr. Liu, what is your thought as the scientific director of CIHR to this idea that sometimes we do research over and over again, we hold ourselves to these very, very high research standards, but, is there an opportunity to really look at perhaps maybe we have enough evidence to justify, let's just get the job done. Your thoughts?
Yeah, no, it's a great question, right? And so, so can we shorten the time to from 17 years down to, on a single hand? So this is, I think, a really important point, and that is that once we do have reproducibility. So we need to be able to reproduce our science, right? So if we have an observation in one particular group, we'd like to be able to validate it in another group, right? So that's a scientific responsibility and reproducibility. That is our responsibility to do. But I think once we're fairly confident about the observations, the next question is, how do you actually apply that in the real world? Right. And so I think the way to do that is, and as scientists, we're not very good at it. And that is how do we involve the practitioners? How do we involve the government policymakers? And I think circling back to the points that Drs. Petrick and Kunz had made earlier, and that is about involving the patients. And so another thing before I forget to say is that the advice that Drs. Burgess and Garber gave to us as Canadians is that we must have the engagement of the firefighters in the science that's going forward, right? So this again circles back to the points that have already been made by Drs. Petrick and Kunz about we must have our firefighters at our side and guiding the science about how it's done, and then working together as patients, as advocates with our policymakers, with the primary care physicians to kind of say, okay, what tools do you need to help us to translate this key observation in order to benefit the audience, whoever that may be, the patients, the Canadians, because our CIHR mandate is to improve the health for all Canadians, and including, of course, our firefighters, as Dr. Petrick said, who put their lives on the front lines to benefit all of society. And so we really need to look after our firefighters. Thank you.
Thank you, Dr. Liu. I'm just going to build on that point for our last question, and then I'm going to actually turn it over to our president shortly to say some closing remarks, because it's our last panel. But you talked about involving people in research, and there's a very special opportunity when it comes to clinical trials. And we had one of our panelists yesterday who faced a rare disease. So take all of the challenges and double or triple it because it's a rare occurrence. And yet we have in our country extensive clinical trials. Can you talk a little bit about the opportunity of clinical trials as a method for patients to get rapid access to potentially cutting edge care if they need it? And we will have just short responses on this one. I know it's a near and dear topic for a lot of physicians and researchers. So I'll just go to each of you quickly and then we'll pass it back to Chief McMullen. So Dr. Petrick, do you want to start on clinical trials and then we'll go to the other two physicians?
Yeah, thanks, Tina. Yeah, I will keep it short. I know we're getting short on time. Yeah, the clinical trials opportunities, and I know lots of people that are on clinical trials, and you're right, it is an opportunity to, if you qualify, to get on in cutting edge research opportunities or therapeutic opportunities. There is a National Cancer Institute, so an NCI organization that oversees global or federally the clinical trials. So there's a website, you can go to the NCI, National Cancer Institute clinical trials website, and it lists all the clinical trials that are ongoing. And so I know physicians will have patients come to them that have been dealing with a cancer, and will say, hey, I see this clinical trial ongoing. Do you think I'm a potential candidate? And then the family physician then becomes the point person that will connect with the people running that clinical trial. So absolutely, there's a repository. Sometimes it's physician driven. Sometimes the physician will say to the patient, I'm aware of this clinical trial. I think you might be a candidate. Do you think you might be interested? But also it can be patient driven, where the patient comes to the physician with that information. And we'll go back to the patient as their best, health advocate, and can say, do you think I'm a candidate for this? So there are opportunities. There's a central repository of all clinical trials ongoing nationally.
Thanks very much, Jim. Dr. Liu?
I have nothing to add. That was exactly the same answer I was going to give. Thank you, Dr. Petrick.
Terrific. And do you have anything to add, Dr. Kunz?
All I can say is, in all kindness and generosity, my primary interest is saving firefighter lives. And I love research. I'm a researcher by training, but we, at this present time, have enough research to know that firefighters are dying left and right of cancer. So rather than clinical trials, which is part of my PhD program, what I'm primarily interested in is practice. What I'm interested in, Tina, is results. So we know that firefighters get cancer and they die of cancer. Now we have to have screening guidelines and implement them. That would be, I would like to stress that most emphatically. I'm interested in results at this point. So we need to get busy and draft guidelines that will give doctors the power and tools that they need to start actually ordering tests like MRIs and complete blood counts.
Duly noted. That's a good call to action. And Dr. Liu, Dr. Petrick, Dr. Kunz, thank you so much. This was a tricky topic and you handled it beautifully. And thank you also for your willingness to lead us in topics that we wouldn't be able to lead on our own. I know the docs like to talk to the docs. And so thank you for your generosity and coming on to the team. And with that, I'm going to turn it over to our wonderful president, Chief Ken McMullen, to give us the final words. And I suspect he might be in an airport. So over to you, Chief McMullen. Thanks for being here.
Well, thank you very much. Thanks for having me. And wow, what a wonderful 2 days as I depart this city of ours in Ottawa after some very successful and meaningful meetings with our elected officials on a whole host of significant issues facing the Canadian Fire Service. And what we've discussed in the last 2 days is certainly one of those concerns and issues that we have. So to everybody, over 160 attendees over the last 2 days, thank you for showing your interest in such an important topic. To all of our panelists, thank you for what you do to ensure the safety of firefighters across this country. And to everybody that listened and was participating, please take from this advice, take from this lessons learned and things that we can all do differently going forward. So for any of us that are out there traveling, safe travels back to where you come from. And again, thank you so much, Tina, staff, everybody behind the scenes that made this happen. Health Canada, thank you for your participation, your continued support as we work through this. And again, we look forward. This is just the beginning of the conversations. There's many, many more to go on this important topic. So with that, I bid you farewell and say thanks again.
Thank you very much, Chief, and thank you to you all. We're looking forward to sharing draft 1 of the report from these sessions. And we wish you well. Have a nice weekend. Please email us and we'll post any of the materials we referenced on the CFC website. So thank you again. Thank you, panelists.